HC3. We are a member-led coalition of healthcare leaders and organizations that are influencing change in our local communities. Today, we're going to focus on opportunities for data to drive solutions in healthcare. With so much data and information swirling around right now amid a global pandemic, it can be overwhelming. Using the right tools and asking the right questions is an opportunity for us to hopefully inspire some solutions today. So that's what we're going to try and do. I have a few housekeeping items. This afternoon's discussion will be recorded, and the slides and source materials for today's discussion should have been shared if you registered this morning, but if you registered after this morning, then it will be shared again via our website and follow-up email. So there's plenty of ways to get your hands on it. You don't have to be like me and screenshot every single slide throughout the presentation. So you can actually kick back and listen and pay attention. As we hear from our experts today, you can use the chat function, which is down at the bottom of your Zoom screen, and just kind of type in questions as you think of it. We'll sort of hold questions for all of our speakers to present and then address them together as a panel. But as you think of it, feel free to drop it into the chat box. So as Illinois and other states start to reopen, residents are increasingly at risk for COVID-19. Beyond access to care, many are also facing other challenges. So here we have Angie Grover, co-founder of Metopio, is joining us to share more about the importance of understanding what's happening through data and how to develop solutions. Angie is going to kick things off, and then she will be joined a few minutes later by Dr. Sage Kim, who is an associate professor at UIC's School of Public Health, to share how she is leveraging data to develop social risk scores that can inform possible interventions. So thank you, Angie and Dr. Kim. Again, just a reminder, just drop your questions in the bottom. I'll leave it to you both.
All right. Thank you, Megan, and good afternoon, everyone. I'd like to kick off our discussion on a positive note. Believe it or not, COVID-19 has really brought to light the importance of data collection and data hygiene. So you can't listen or read any news story that doesn't cite some COVID-19 statistic, whether that be numbers of positive tests, the death rate, patients hospitalized, or communities most impacted. There's a lot at stake, and many decisions are being made on these numbers. Unfortunately, the data is imperfect and incomplete, but this is what we've got to work with. So let me start. I want to frame our discussion today for the experts on the panel by touching on a few of the variables that impact what we see in the data. So first, as an infectious disease, all positive COVID-19 tests have to be reported to the health department, but there isn't a similar mandate for negative tests. So this varies across the country. At a national level, one CDC nuance is their reporting does not include any private lab tests. So already we're seeing some gaps in the data. Second, we are working with our vital public health system, which is a network of local agencies that provide care, coordinate, collaborate, and roll up information to state agencies. Each one is funded differently, and there's a wide variation of resources, technical skill, and staffing from place to place. There's even variation in the geography that the departments cover. Some examples of the challenges facing these departments include a limit on the queue for receiving data to 1,000, meaning that if the epidemiologist does not process the queue of data, no additional data can be received. And just across the border in Wisconsin, one public health agency has 85 different programs for receiving and analyzing data with limited staff. So when we look at what is being reported, we also find similar discrepancies. For example, how deaths are defined vary by jurisdiction. Oregon State reports COVID-19 deaths as those who died from the disease, while Washington State reports them as those who died with the disease. This is not just semantics. Illinois uses the definition like Washington, reporting those who died with the disease, but Dr. Ezike has said that those numbers could be adjusted. At the same time, the Sangamon County coroner has said will not be adding COVID-19 to death certificates unless the individual died from the disease. So these inconsistencies remain. Then just about a month ago, on July 14th, the Trump Trump administration issued guidance that the Department of Health and Human Services would now be collecting COVID-19 data rather than the CDC's National Healthcare Safety Network site, raising concerns over continuity, timeliness, and transparency. Needless to say, shifting policy in a politically charged environment, layered on top of the operational challenges of a decentralized public health system, make data collection and standardization very difficult. Before I move on, I also want to note that another variable impacting the data being collected is how many tests are available and who is getting tested. So way back, it seems like an eon ago, but on February 29th, the FDA loosened the regulations on the development of COVID-19 tests. But before this date, all the tests had to be conducted by the CDC for a case to be counted as confirmed positive. So that narrows the pool. Then on March 13th, the US declared the coronavirus a national emergency. So prior to this time, tests were extremely limited. As such, testing was prioritized for those who were already sick and coming to the hospital, which means that the population also had an increased chance of adverse outcomes. On May 18th, HHS announced that the CDC would distribute $10.25 billion in funding for state and local jurisdictions to do testing. And as of today, there are viral tests and antibody tests, but there are no at-home tests. These continue to evolve as science races to keep pace with the pandemic and will yield varying data based on their efficacy and availability. Another silver lining is the recognition that we really must collect race and ethnicity data to understand the disproportionate impacts of COVID-19. As of June, the American Medical Association reported that 14 states are still not collecting race and ethnicity data for COVID-19 deaths. The COVID tracking project, however, shows that as of July, 47 states are collecting race and ethnicity data for cases of COVID-19. Illinois was a leader on collecting race and ethnicity data across all categories, but that means that the national data set is still incomplete. While there are many efforts to provide consistent national daily updates for researchers and decision makers, only 13 states provide data at a state level in a machine-readable format, which means data collection is very inefficient and time-consuming. So those are just a few of the variables that make this data set challenging, but we have the data, we need to use it, now what? So I want to conclude my opening with two examples for you. Just a moment. This first one compares zip codes in Chicago. So I want to focus on why we should use rates and why we need to draw from stable data sources. This slide compares two zip codes in Chicago, 60629 and 60633. Cases are typically in the news, et cetera, reported in absolutes, and people know their zip codes. So this is a commonly used reported format, not in the clinical environment, but in the news cycles. An interesting side note, zip codes came into use in 1943, but weren't finalized for 20 years, and they're not defined by population. They're defined by location, which means the number of people living in any zip code varies widely. So on this map, the darker blue indicates a higher number of cases. So when comparing the two zip codes, the COVID impact looks far less for 60633. Here though, if we compare 60629 on the left side is the case number comparison. So this is a raw number. On the right is the case rate comparison. And you can see that this shows that the COVID-19 impact for people who live in the South Deering neighborhood is much closer to that of 60629. This is the kind of comparison we should use to inform our decisions. Finally, we must use this incomplete and imperfect data, but how do we do that? This slide demonstrates how COVID-19 data in context can be helpful. The Harvard Chan School of Public Health did a study using data about diesel particulate matter from the EPA to understand COVID-19 deaths. We replicated that study on Metopio, which looks at COVID-19 data as of August 9th against the EPA data set. This scatter plot, which is what you're looking at, examines the relationship between these two topics and clears out some of the data noise by controlling for 7 variables. These are things such as median income, median age, sex ratio, high school graduations, and things like that. This really lets us get to the correlation between communities with high levels of diesel particulate matter and the greater number of COVID-19 deaths. This analysis uses a stable data set in conjunction with current COVID-19 data to give us something to further investigate as we try to understand what populations have the greatest impact. And this is a perfect opportunity to turn to Dr. Sage Kim, Associate Professor at the University of Chicago School of Public Health, to share her great work around vulnerable communities and COVID-19. She'll share with us how she's used various data sets which help us understand community context and really make better decisions during the course of this pandemic. Dr. Kim?
Hello, everyone. I'm Sage. Thanks for this opportunity. So I've been looking at COVID-19 related data since the beginning of March, and it's been really difficult because of sort of limited or lack of necessary data to understand the impact of COVID-19 and particularly racial ethnic disparities in COVID outcomes. So I'm going to share with you some of the ways I utilize the existing data to understand vulnerabilities to COVID-19, which contribute to racial ethnic disparities that we see in COVID infection and death. And I hope we can talk about the importance of data supporting evidence-based decision-making and community engagement in data production and policy making. So this here, just to summarize where we are, we've been practicing shelter in place since March 20th, and which effectively brought the infection down in Illinois, but the trend began to reverse since mid-June. So looking at the number of new cases, the weekly new cases went down to about 4,000 cases by the third week of June, but since then the number has gone up again, and as of now we're up to the level where we were back in May. But the good news is that unlike the number of cases, the number of deaths had sort of leveled off since mid-July. Next slide. So the racial ethnic disparity distribution of COVID infection and death have changed over time. During the early pandemic period, African Americans represented over 50% of COVID cases, followed by whites and Latinx. But the trend began to shift, and Latinx cases exceeded white cases by mid-April and continue to increase. Now, Hispanics account for 48% and African American account for 30% of Chicago confirmed cases since the end of May. In terms of death, again, Latinx death cases continue to increase and now account for more than 30% of the Chicago COVID deaths, and African Americans still represent over 40% of Chicago COVID deaths. Next slide. So how do we understand racial ethnic disparities in seemingly this natural disaster, right? Vulnerability is a key concept in understanding risk and outcomes of exposure to disasters and hazards. Risk as a technical term is very narrowly defined as a values neutral term, but vulnerability, in fact, is shaped by social, economic, and political context. And so, as they say, nothing natural about natural disasters, right? In fact, social structure produces inequality, and because it's structural, we see similar patterns of vulnerability in many natural and man-made disaster events. We saw racial disparities in Chicago heat wave in 1995. We saw a similar pattern in Hurricane Katrina in 2005, Hurricane Maria in 2017, and now COVID-19. So I'm using social vulnerability index to characterize more social and structural vulnerability to COVID-19 and consequences of public health mitigation policies. Next slide. So social vulnerability index is a composite score created from socioeconomic measures, including poverty, education, household composition, household income, and labor market participation. So actually, some people actually ask me why I didn't include race, ethnicity in the index. It's because first I'm interested in comparing racial ethnic groups, right? Race, ethnic differences in social vulnerability. So I exclude racial ethnic composition from the index. And secondly, I think it's more important, it's because there's no reason to believe certain racial ethnic groups are inherently more vulnerable than others, right? We use race ethnicity simply use as a proxy for social disadvantage. So I'm actually removing race ethnicity from sort of the level of social vulnerability to be able to compare racial ethnic groups and communities. Also, I created a health risk score to take into account existing comorbidities that contribute to poor COVID outcomes. So health risk score include the rate of heart-related death, stroke death, asthma, hypertension, diabetes, obesity, and smoking. So next slide. So now look at the distribution of COVID-19 infection. North Lawndale in Little Village, Brighton Park, Chicago Lawn, back of the yard are some of the communities with the highest COVID infection rates, except for Lawndale. These are mostly Hispanic communities. Next slide. So now looking at the death rates, South Shore has the highest death rate, followed by Inglewood, Austin, and Roseland. So these are predominantly African American communities on the south and west side. And now Rogers Park and Little Village are the communities with high rates of COVID death. Next slide. So here I compare social vulnerability and health risk score along with the distribution, the distribution of COVID deaths. As you can see, high levels of existing health risks. It's concentrated predominantly on the south and west side, which are community areas with the highest COVID deaths in Chicago. So if we had better data on existing comorbidities, it would have been extremely helpful to prepare for responses. But currently, these health risk data are very difficult to find outside of Chicago. I tried IDPH data to create health risk score for Illinois, but IDPH data is at the county levels. And as you can imagine, county level health data are just too general, right? So there's again, the importance of having this health, baseline health data in preparing for sort of incoming pandemic, I think. Next slide. So beyond the immediate health impact of COVID, the pandemic has significantly affected the economy. Since March, more than 40 million people filed for unemployment. Currently, the Bureau of Labor Statistics reports that more than 13% of an unemployment rate, but the actual unemployment rate is estimated to be more just over 23% in July. In Illinois, the unemployment rate is over 15%. More than 700,000 jobs were lost. These are mainly low-wage jobs. And 40% of low-wage jobs lost in Chicago were in the accommodation and food industry, followed by administrative, retail, and health social services staff. As you know, the majority of these low-wage workers are racial ethnic minorities. Next slide. So when I initially looked at the low-wage job loss between March and April, it looked like the largest job loss occurred in relatively middle-class areas, the map on the left, right? But this shows where the jobs were, right? So I had to do additional steps to figure out the characteristics of the workers who held these jobs that were lost. So I combined other data sets like the longitudinal employer household dynamic data, and the map on the right shows they actually these are workers who the jobs that are lost and the characteristics of the workers who lost jobs. So actually the majority of low-wage workers who lost their jobs were Hispanic, the red dot, and African-American workers, the green dot. All right, so next. So one of the federal interventions to tie workers to their jobs was the Paycheck Protection Program. So the PPP data showed that more than 174,000 businesses received small loans under $150,000. In Chicago, there were over 34,000 small businesses received the PPP loans. The map here shows the number of PPP loan received by zip code. This showed that PPP went predominantly to north side communities, while the number of PPP was significantly lower on the south and west side. You know, it's possible it's because there are more businesses on the north side, but you know, we'll need to examine more detailed the data with the conjunction with the actual business distributions. But this the next slide. Right, so the eviction moratorium ban is another executive order officially ended in July, but it'll extend till the end of August. There's no data on eviction rates, but looking at the previous patterns, we can assume who's going to be most more vulnerable. Here, historically, the eviction rate was significantly higher in the South Side community areas, so we can expect the potential housing issues may be severe on the South Side. So to conclude, this pandemic exposed not just the vulnerability to our system, it also shows the significant need for better data, right? My experience working with COVID data so far actually has been amazing. Not that we have sufficient data to make evidence-based decisions, but everyone recognized the importance of reliable data and quickly organized and formed collaborative teams. It's been truly incredible mobilization and coalition building. And we at UIC School of Public Health launched a new data center called the Public Health Analytics, Metrics, and Evaluation, FAME, in collaboration with Metopio. I'm a co-lead of the center. The center aims to build data repository and catalog sort of common measures for health equity research policy and community engagement. I think for clinicians and service providers, having social determinants of health screener questions may be helpful to quickly identify who needs most support. And the last thing is that the data cannot really sit in an academic center. I think that the community engagement is crucial in data collection. So we have citizen scientists collecting data and dissemination and policy making. Thank you for your time.
Thank you, Dr. Kim and Angie, for this very insightful presentations and thoughts. We're just gonna quickly shift focus for a moment to take a deeper dive into some of the risk factors that around specifics, such as access to housing and homelessness during the pandemic, with someone who I personally think has invested a lot of time and energy into this issue. So joining us now is Stephen Brown from UI Health, building to share more about his thinking around the effective cross-sector partnership to address COVID among vulnerable housing populations of Chicago.
Mm-hmm. Thank you, Megan. Good afternoon. My name is Stephen Brown. I'm the Director of Preventive Emergency Medicine at the University of Illinois at Chicago. I'm going to be talking about addressing homelessness during the COVID crisis and the potential housing crisis that is on the horizon for us here. I am the Director of Preventive Emergency Medicine and the Director of Better Health Through Housing. UI Health created one of the first healthcare to housing programs that identified the emergency department patients and referred them into permanent supportive housing. We've housed 75 to date and expect to refer another 20 this year. I should also say that in a previous lifetime, I used to work for Motorola and was a systems engineer there. And then during a sabbatical where I got my master's in social work, I supported myself by building dynamic e-commerce websites. So I'm not a very good technician anymore, but my skills are way out of date, but I do appreciate the need for bringing large amounts of data together to inform public policy and for further clinical integration. I'm also one of the founding members of CHARGE, the Chicago Homelessness and Healthcare Response Group for Equity. We're now a formal organization that has over 100 participants with 15 healthcare providers and 12 shelter agencies. It started in early March as an medical and shelter providers led by Rush University. We met out of a deep concern that the logarithmic pace of COVID transmission would soon invade shelters who often had several hundred residents per evening, and that these shelters had the potential to become super spreader sites. Rush, Cook County, and UI Health have had programs that assist the homeless. Rush provided medical care at Franciscan Shelter, and UI Health has a Better Health for Housing program. And Cook County Health has also joined the Flexible Housing Pool in Chicago and has housed an additional 75 patients to date. Very quickly, we were joined by healthcare providers, Lawndale Christian Health Community Center, Heartland Alliance Health, and representatives from Franciscan Outreach, Pacific Guard Mission, the Salvation Army, Breakthrough Urban Ministries, the Boulevard, and Cornerstone joined us. Almost immediately, we were faced with a 50% reduction in shelter bed capacity. And what limited us in those moments were just to know what the bed capacity was and who was still accepting patients. As we were trying to isolate in hospitals, we found that we couldn't have people waiting in waiting rooms any longer. And the potential for community-acquired COVID would be greater in these waiting rooms, and yet we couldn't transport our homeless individuals. So part of our conversation with the city is how do we build that kind of transparency so that we know in real time what might be available. Many of these, we had homeless people living in large congregate living facilities or in sanitary encampments, and we were seeing an uptick in overnight transit riders and encampments. The focus of this talk is to foster solutions, so I'll not be able to describe much of the amazing work that was done by this dedicated and passionate group. I wish I had the time to describe the heroic efforts and the ability to quickly organize into an effective rapid cycle crisis response entity. I made lifelong friends for which I'm deeply grateful, and we plan on having a socially distanced picnic at the end of this month, and most of us, it'll be the first time many of us have met in person. During the pandemic, we operated 7 days a week for 2.5 months, meeting twice daily between 8 and 3. We self-organized with frontline doctors and nurses and added logistical support for acquisition of PPE and disinfectants and staff education. And if you recall, PPE was in very short supply for hospitals, almost non-existent for non-healthcare facilities. Within 3 weeks, we had created the logistical supply chain, screening and testing protocols, and staff educated that mitigated outbreaks in 5 of the city's largest crisis shelters. Our colleagues at Lawndale Christian Health Center manned Hotel 166 to host the most vulnerable of the homeless. At its peak, we had 170 occupants. In terms of vulnerability, the homeless are some of the most vulnerable in our population. They have life expectancies that are 27 years less than the average American. About 70% are African American in Chicago, and many have multiple medical comorbidities as well as high rates of mental illness and substance abuse. I've looked at comorbidities at this population. I can tell you that for the 60 individuals in the Better Health for Housing program, 70% had asthma or COPD, 65% had hypertension, 40% had chronic kidney disease, 25% had diabetes, 20% have cancer. And if you know the CDC guidelines for the most vulnerable of those susceptible to COVID mortality, you can see that many of those diseases are on that. One of the interesting data things that we did for the city once we got to operate with them was they asked for advices among the population of the homeless, how many of them met the CDC's criteria for high-risk individuals. So I was able to mine our data. I looked at about 1,700 individuals who were identified as homeless at UI Health in 2019, and then compared the CDC risk factors. It was a whopping 62.7% of the homeless population had those CDC risk factors. And fortunately now with our work with the Chicago Department of Public Health and the Department of Family and Support Services, they have taken our recommendations and will be prioritizing these high risk individuals for housing, an increased number of supportive housing units that will be coming online due to the CARES Act. As it regards to substance use and mental illness, we found 68% had a psychiatric disorder and 57% had a substance use disorder. And in our partnership with Northwestern, we've observed that these rates to be at least double what is reported nationally for the homeless. Something here is driving these rates of morbidity, but we don't understand why yet, and this is where we could use your help. I can tell you that the mortality rate is very high too. In the first cohort of the Better Health Through Housing program, which we have been tracking since 2015, our mortality rate in 26 patients has been 38%, or almost 4 in 10, a very stunning rate. I think we can all agree this is a dangerous health condition. And yet one of the challenges we have with data is it's very difficult to acquire. We have no way to report homeless mortality yet. We are working with the Illinois Department of Public Health to be able to pull some of that data. But there was a city official that said early on that there had been no homeless deaths. And that kind of raised our eyebrows because we just don't have a way of reporting it. So within the charge group, that is one of our initiatives to be able to track homeless mortality rate. We know the mortality is rate, we just have no way to get to the data yet. Regarding the pending economic and housing crisis, first of all, the country was at a tipping point way prior to the COVID pandemic. We had record rates of economic inequality, and with the majority of the increase of wealth going to the top 5% of all Americans. Here's a quote by Orrin Cass, director of American Compass. A dramatic divergence between data and experience is confounding Americans' policy debates. The data seems to show that households have attained unprecedented prosperity with wages at worst held their own against inflation, or at best risen much faster than prices. By conventional measures, material living standards everywhere in the economic distribution are at all-time highs, and technological progress continues to improve them. Yet many jobs able to support a family in the past no longer do. Millennials are in worse financial shape than those of Generation X at the same age, who themselves had fallen behind baby boomers. The stories appear irreconcilable, end quote. So in 2017, 55% of US adults reported struggling with some financial concerns, and 17% were struggling with all or nearly all aspects of their financial lives. While very high wage workers have seen increases of 41% since 1980, middle-class wages have increased just 6%, and low-wage workers have seen a net 5% drop contributing to an ever-widening wage gap. There's also profound Black-white wealth gap, revealing the accumulated effects of inequality and discrimination. An examination of U.S. family wealth found the difference between white and Black families to be staggering. A staggering tenfold difference, 171,000 for a typical white family versus 17,650 for a typical Black family. A generation ago, a typical male worker could cover a family's expenses of 4 major expenditures, that being housing, healthcare, transportation, education, on 30 weeks of salary, leaving 22 weeks of pay for everything else a family wants and needs, such as food, clothing, entertainment, and savings. By 2018, it took 53 weeks just for the 4 major expenditures. American families have been and are now going under. Now, with the rates of unemployment skyrocketing and businesses failing at a record pace, we are at a tipping point. Mortgage delinquencies hit an all-time high in April. 32% of tenants and homeowners missed some or all of their rent or mortgage payments in July. And there are estimates that if the pandemic persists, we could witness 28 million vulnerable Americans becoming homeless. And we may be facing a housing crisis here in Chicago. Nearly half of renter households are burdened financially. 43% report paying 50% of their income and living in severely rundown units. Most of the development of new apartments cater to higher income renters. High income renters increased 3%, the highest of any income group. Prior to the crisis, we had a gap of 186,000 affordable housing units needed, shortage. And as Sage mentioned, there's a fear of an impending eviction crisis as the moratoriums will expire soon. Our charge group is concerned that this will result in increased rates of newly homeless and that instead of single adults, families will be pushed out, creating a dilemma since there is already a severe shortage of family shelters and transitional housing that existed prior to the crisis. So far, we have not seen the spike in evictions, but we are monitoring other cities where moratoriums have already expired, but changes could happen rapidly. I think what we're seeing is a rapid expansion. One of the short-term effects is a rapid expansion and contraction of the economy as precautions are loosened or tightened, primarily because service workers in retail and restaurants are often the first called back or let go. So we need your help. Who among our residents are most vulnerable? How do we intervene when someone is pushed out of their home? That's too late. From my conversations with Metopio and TransUnion and Carrot Health, a startup out of Minneapolis, the mining of big data offer early warning sign. I'd like to start that discussion.
Thanks. That was great, Steve, and we can dive into that discussion. Just a reminder, if you have questions, to just use the chat function and I'll keep an eye on it and start kind of working through them. One that came in early on, and we can give you a moment to catch your breath, Stephen, and I'll address this with Sage and Angie, is why is the percentage of female headed households included in your social vulnerability index?
So it's a convention. So percent female-headed household with dependent children is known indicator for burden, not only economic burden but also sort of difficulty, especially in disaster events. They're the ones who need to move quickly to sort of move out of disaster areas. So in sort of disaster research, female-headed household with dependent children is considered to be more vulnerable. But in general, sort of economic sense, that indicates economic burden as well. Sure.
So as we prepare for whatever our next disaster is, since you mentioned a couple of things like especially for Chicago, the 1995 heat wave was a huge influx of what that vulnerability was and the deaths of people that were dying from that heat. And as we look at, as we're reacting to what's happening right now, what do you think we can use in from these indexes to inform us and how to improve and what we can be taking away to move forward?
Right. Before I actually say something, Angie, you had an example. You're telling me about social vulnerability index and how it's used. So do you want to talk about it a little bit?
So Dr. Kim has been very gracious, and her social vulnerability score and her risk health factor score are both on Metopio for anybody to access. And we had a health system looking for places to put their testing. And so they used the scores just as a composite of all these multivariates that you put in to really look at a comprehensive way of where they should put testing sites, where risk is the greatest, where community need is the greatest. And so it was really great. And it's one of the things at Metopio, we really are driven by liberating data so people can use it to make decisions. And we're fortunate that Sage has shared her scores so that people can use them and look at them for places that they really care about.
The other thing that I want to say is that social vulnerability index that, it sort of got me into this amazing, circle of people who, community members and organizations who want to make decisions about where to put resources and do we need a testing site, additional testing site, for example. So I got into this conversation, particularly with community sort of organizations. So social vulnerability in a way, in general, like we can actually look at the big picture, sort of Illinois big picture, where the most vulnerable areas, but also it sparked, really interesting conversations with a more localized, sort of decision making.
Absolutely. And then Angie, as you think about the quality of data, I know that you and your team have certain standards of what is put into your database and how folks like Sage and our community members can utilize that in a way to do these measures. Someone asked on our chat, how is the fax machine affecting data availability? It seems like it's a problem for COVID test forms. So what are your thoughts on just the collection in itself and how it's being disseminated, and then how it gets to people like you where you're actually kind of working with that data?
Yeah, we don't deal, COVID is the first data set we've really updated real time. We look at aggregate data. And so I think I think we can all agree that we shouldn't be using fax machines anymore if people still have them and can find them. And I mean, it's really ridiculous. And talk about timing. Somebody has to remember to go check it. So I think, the great thing, in every disaster, there's a silver lining. I think people are really paying attention to how data is collected, what needs to be collected that's important to look at, and how they do it. So we really rely on a lot of the bases, a lot of publicly available data that's curated and aggregated so that you can look at it apples to apples across all these disparate topics. And we feel like that's a great way to inform decision making that goes beyond your real-time reporting and individual patient level. I mean, you can follow one patient from place to place and try and take care of Angie Grover, but it really is the place where there's a whole bunch of Angie Grovers that you can take care of, that you can leverage your resources. So that's really how we try to look at data. And I think to Sage's point, this has elevated the conversation about local data collection and how you can help incentivize that and share that data in a more widely share it more widely. And the last thing I'll say, and I know that both of these folks can weigh in, is that government data lags quite a bit. And so, we're in the midst of COVID looking at real-time data versus some really rich and stable data sources. But it's going to be a while before the government data catches up with the impact of COVID. So I think what Dr. Brown and Dr. Kim are doing is really important, looking at where we can get COVID data and then looking at how to use it with these other data sources, because it's just not going to catch up very quickly.
Yeah, if I might pipe in on this too. To Mike's question. So one of the challenges we had were we have several homeless individuals that go from ER to ER, and we might have tested them at one facility, but the other didn't know about it. And so I got a call from the fire department they wanted help with one of their super users. This person had 61 transports in 60 days to 12 different ERs, and he was COVID positive, right? And in all touched 270, or had contact with 277 CFD members, let alone all of the ED staff, right? And yet we couldn't report that data to each other. That's an ongoing issue we're trying to do. When you get to public health reporting, it's also a very manual process. And we needed real-time information. We were looking at something called patient ping to be able to report these things. Unfortunately, they took a pretty conservative thing. They wouldn't report positive tests, only negative tests. And so that could have been a promising thing if we could have overcome some of the HIPAA hurdles in this, but we didn't. We recognize the need that, especially when it comes to infectious diseases, we need to be able to look up each other's results and be able to respond accordingly to those individuals.
Yeah, and then as you think about how, I mean, you've been working with this vulnerable population since before COVID, and this just compacts that issue. But then during COVID, what is, someone is asking about, what are the closed loop referral services looking like, and how have you guys been managing that? And so with all of these things, you know, a lot of these platforms that host that information, there's a lot of places that are closed too, and there's a lot of misinformation and a lot of things changing. So how are you working with patients and tracking some of that?
So I can say, so I actually was the author of the first online resource directory. It's called southsidehealth.org. And two things spun out of it, NowPow and Purple Binder. They were out of that original project. And so this is very near and dear to me. As we are now have awareness of social determinants of health, we have a long way to go to fill the gaps. And there's still a large gap between healthcare and human services. The closed loop concept is a really good thing. No, people aren't doing it very well right now, but we really need it. And that's what the government is telling us to do. The Accountable Health Communities RFP that went out a couple of years was trying to bridge those gaps to be able to and create the data infrastructure to see if somebody actually got a social service, did it have an effect on health. I can tell you some of those studies that came out of that didn't really have much effect, but that is still probably the most formidable challenge that we need to address, because it's such a structural issue. Like social service agencies are funded on grants. We're funded on reimbursement. And so there's nothing until we can offer a value-based payment to social services. I don't think we're going to be able to attract them in ways in which they would form partnerships with healthcare organizations. Personally, what I'd like to see as a healthcare provider is what we call super CBOs, super community-based organizations. So I don't have to do individual contracting with each social service agency. I'd like to have a large organization where it's one-stop shopping for me. And then I want them to be able to report back there. There are some efforts going on in Chicago right now. The Illinois Public Health Institute has a planning grant through the Pritzker Foundation that would do what we call cross-sector data exchange for two reasons: is pull together public health data out of their silos and into a central repository where this data becomes actionable. And then looking at clinical care integration. So if I make a referral out of my healthcare system, what everyone wants to know is that often these folks have complex needs and they want to be able to see who else is helping manage that individual. If there's a caseworker in a social service agency, that person's relationship is a very valuable thing. And so who could help us with managing the care? Oftentimes what we don't see in healthcare, we might have a social worker that has an interaction. There might be 5 or 6 other people that are helping with various services that individual needs that we don't have access to. So that's however we do that. And and I'm working with Care Advisors, the Matter company, to consult on this very issue right now. How do we bridge this gap? Right now, hospitals have to do it a DIY way. We need vendors to be able to hand us a solution on this.
Yeah, and then Angie, we've talked before about how your platform, you've worked with certain partners to address kind of from a zip code factor. It's also like, the accessibility of these things. So can you talk about how you've measured where food pantries are and sort of the service area of some of these resources that people are trying to access as well?
Yeah, we're able to take that data and aggregate it up so we can look at where, you know, it's just like where food deserts are, where are all the groceries and where is the need. And so Metopio is really designed in order to look at that disparity and put those two data sets together. So, you know, when you look at where the pantries are, we actually embarked on a project with a client who was looking at where people could get resources outside of like the depository and that kind of thing. And a lot of these, as you know, are in church basements and in other locations that were closed or you couldn't get in contact with someone. So, you know, I really appreciate all the work that Purple Binder and NowPow and organizations like that are doing, because it's that in aggregate against the need. And when you look at those two, the gaps are so glaring. And then we get to, you know, Dr. Brown's supposition that how do we fill those gaps? Because there's no incentive to do that right now.
And
So
I'll just add to that then, I'm sorry,
go
that
ahead.
when we looked on the south side of Chicago, we found about 1 in 5 social service agencies were off the map. They were informal. They were in church basements, as you said. So undiscovered assets in the communities. I'm sorry, Sage.
Oh, I was going to say that technology might help, you know, sort of solve this problem. You know, Amazon does that, you know, like Walmart inventory sort of real-time updates. So I was meeting with the innovation center people, and, you know, there was a sort of idea of app that provide, you know, real-time social services, you know, where, you know, which food pantry has what type of food, and then delivery. And it was actually about housing, you know, homeless housing unit, particularly interested in, you know, sort of social service providers know exactly where the opening tonight, you know, might be. So I think it'll be so interesting to sort of invite in innovative technology people to come up with this integration and real-time sort of spotting type of technology, I think.
Angie and everyone, I'm wondering what you all are thinking as far as like with the census being pushed up now, what challenges we might see with data. And also, I mean, it's going to come down to, as I like to call it, the $1 million question of who's going to pay for things and how much money are we going to get for our state and things like that. So what are some of the other challenges that we will see come from the lack of data or the sort of maybe not fully formed version of what we probably need?
I started the panel by describing just what is happening with COVID data. It's even more frightening when you think of what could happen with incomplete census data. You know, part of me, when I'm a mom of 2 young kids trying to deal with school right now, and everybody's talking about unenrolling their children, and I'm trying to make the point that a 3-year rolling average for funding is going to really hurt us if you unenroll. And so part of me is like, we need to redo on 2020 on so many levels, but we really need to be cognizant, and we really need to form these partnerships that look at data in a very public and transparent way, because we're going to need to fill some serious gaps. There's no, I mean, we have everything from the political, we have redistricting coming up to where resources are, the census is once every 10 years. So it has a really long tail, and depending on how decisions are made at the federal level, we may have to have a redo on the census, because I don't know how an incomplete census can form the next 10 years of policy.
And I think that there's direction to it, you know, sort of invisible man, right? So undercounting of certain group of people actually skew the data, not just randomly undercounting, but a certain group of people, which is, again, an important issue in terms of racial, ethnic inequality going forward.
And then, Stephen, one other thing that you touched upon, but I'm wondering what, I mean, we have to be forward facing now, and I'm wondering what your thoughts are on if there's any predictability on what the affordable spending pool for housing will be. I mean, especially with some of the factor we've sort of, it keeps getting pushed and pushed and pushed. You probably will predict it might be pushed again. But what sort of things do you anticipate given some of the other crises that we're facing with rent burden and other things and eviction issues?
So the city did issue a 5-year plan for housing under the previous Department of Economic Development, I think it was. I forget the exact city department. And it was actually some pretty innovative reforms recommended. So in the past, any new development of a certain size over so many units, there needed to be a 10% set aside, either in units or in the total cost of construction. And most of those developers would opt for just putting it into the real estate investment trust. I'm not naming it right. But there is a public trust where money can be put set aside for affordable units. But what that did, though, is then that money was used generally in under-resourced communities and not in the most affluent. And so it only contributed to a lack of diversity within some of the highest income neighborhoods. So now there will be some reform in those things that would stipulate that it has to be within a mile or mile and a half or something like that. So the monies, they can continue to set aside. Very few of them choose to subsidize their units within the buildings, but it has to be within the bounds of that neighborhood too, so that we maintain economic diversity, or at least try to claw back some of it that has been lost in the last couple of decades here.
Yeah.
I think just getting to one of the first things that the report that I mentioned, we have a shortage of 186,000 units. That was done 2 years ago. And I think that was the first time it was done. So at least we have the numbers. It gives us something to organize and a goal to address. We are also trying to increase the number of supportive housing units through the flexible housing pool. We have about 8 million committed in investment so far. We hope to be able to have 12 million totally funded. When we do that, that is the ability to either identify 700 existing or help finance new units. So it'd be 750 units. In Los Angeles, there's a partnership between the county and the city. They have a very similar model. Theirs has additional funding on it. They're able to build about 3,000 new units a year on that too. But it's also this recognition that this wicked problem we have of homelessness is just that, a wicked problem, and we need collective impact. It comes from healthcare systems recognizing the impact of health on homelessness. It comes from government agencies that see people that cycle through the criminal justice system, through first responders, through shelter systems, social service agencies. It comes through managed care organizations, and it comes through private philanthropy. But each one of us trying to do this work on our own, we will have no impact. It has to be collective impact. In Portland, 10 hospitals got together. It started with a CEO breakfast that happened once a month with a guy that ran a supportive housing organization called Central City Concern. And with 18 months, they'd come up with a plan. And those hospitals committed $21 million towards affordable housing. So we can't go this alone. It has to be collective.
My last question for everyone was going to be, what do we do next? And I take that as your answer, is that we have to work together collectively to move the needle on this issue. Sage and Angie, do you have any final thoughts?
I concur. I think that's a great sort of summary of what we need to do now. We really need to work together.
And I would just say we need to keep advocating for sharing that data, as much data as appropriate, and collaborating across from the local up through the federal government, because we can't make these decisions in a vacuum, and everybody realizes that healthcare is closely tied to the zip code you live in. And so you really need to know about that zip code, and it doesn't always show up in the EMR.
Yeah, and I think our state officials would like that too, because we could get to evidence-based policy. Right now we're guessing, right?
Evidence-based policy. That is a great note to land on.
our next chat. Well, thank you all so much for your thoughtful conversation and for doing what you do every day and contributing in such a positive way to our system and our community. Just for anybody on the call, thank you for joining us. We have another event next Wednesday. You can check it out on the HC3 website. It's with Jamal Cole as part of our Emerging Leaders series. He's the CEO and founder of My Black Mindset, My City. So it should be a really nice way to capstone this with somebody from the community in our next conversation. So thank you all again for joining me today, and everyone have a good afternoon.
Thank you.
Thank you.
Bye.